The next talk will be about the safety of microbubbles. Why are we dealing with safety? Because one of the first things that we learn when we start to study medicine is that we don't have to harm our patients, primum non nocere, since more than 2,000 years. So how can we harm our patients with ultrasound? Conventional ultrasound has been used since long without reports of any significant side effect. So now, should we worry about the additional risk brought around by using contrast agents? And what are these risks related to? There are some aspecific, not specific risks, which are really marginal. They are related to vein puncturing, like bruises, infections, so they don't have anything to do with the contrast agent itself, but are related only to the fact that we have to put a needle through the skin of the patients. And then we might have, theoretically, some additional specific risks related to the substance that we inject, which is the contrast agents. Theoretically, there could be some specific biorisks. Biological damage might be brought by the insonation of ultrasound with gaseous particles and might be produced as thermic or mechanical risks. And this is due to the interaction of ultrasound waves and gas bodies, because this interaction increases the probability of cavitation. And the World Federation of Societies for Ultrasound in Medicine and Biology recommend that any physician should take this into account when considering the benefit ratio of an examination. And these theoretical risks come from some in vitro and animal studies that have shown adverse effects of ultrasound contrast media related to the properties of the particles and the interaction between microbubbles, destruction, and ultrasound beam energy. However, it should be noticed that this could be demonstrated only by dedicated experiments with microscopic examination of the sacrificed animals, and there were not, let's say, clinical events in animals. So we have, on one hand, theoretically some tissue damage that can be observed at microscopic examination after the interaction of ultrasound waves and gas bodies. And on the other side, we have the clinical situation, whether we should ask ourselves, are we potentially producing some clinically relevant effects, or is it only microscopic damage, like if we were pushing on the skin? Clearly, to answer these questions, before any drug, any agent can be brought into the market, there are some studies which have to answer this question. And also for contrast agents, there have been some phase 1, 2, and 3 studies. And clearly in the phase 1, phase 2, and 3 studies, patients are usually selected with absence of risk factors, but at least there are no known risk factor for contrast agents. So these patients should more or less represent the general population. This is, for instance, a phase 3 trial about dodecafluoropentane emulsion, which is what's called Ecogen. And you can see that the rate of events in patients treated, injected with a system under investigation or with placebo was similar and was very low, because the rate of any adverse event was less than 10%, both in patients injected with the agent or with placebo, and no specific event was more often met in patients treated with the agent. This is another contrast agent that was tested, and also in this case you see that different dosages of the agent did not produce substantially different and increased rate of events in comparison to placebo. And all the events that were observed were mild, and only a few could potentially be directly related to the agent due to an allergic mechanism. But the rate was very low, and the clinical manifestations were mild. We know that contrast agents for ultrasound are excreted to the lungs, so one might wonder whether patients with lung disease may have a prolongation of the half-life of these agents, and this might translate into some adverse event. Therefore, there was a need for investigation in this case, in this situation, and SonoView indeed was tested also in patients with chronic obstructive pulmonary disease, and the rate of event in patients was the same as in patients treated with placebo. So taken all together, all these studies showed that the reaction to ultrasound contrast agents in studies that were dedicated specifically to investigate the safety of these agents did not show any specific organ-related damage. Consequently, no blood chemistry exam is requested before undergoing CEUS, and up to now there is no report of nephrotoxicity, nor patient's history is necessary apart from previous reaction to ultrasound contrast agents, and we will see later to the cardiac status. But we don't need any specific blood examination, biochemistry investigation before we can inject an ultrasound contrast agent to the patient. We only have to very briefly take the patient history. So if ultrasound contrast agents appear to be that safe, why are we talking about the safety of CEUS? This comes from some post-marketing observation of a few cases of patients with a temporal relation between the injection of contrast agents, and in this case it was in Europe, it was SonoView, and death. 3 serious events with fatal outcomes were observed in patients with coronary artery disease. And this brought to a stop of the use of SonoView at that time, and the decision of the European agency to make investigation on whether there was a causal association or was just a temporal association with no relation between the injection of the agent and the death of the patient. After the subsequent reassessment that was decided and carried out about the risk-safety profile, it was decided, it was established that the fatal events were related to idiosyncratic hypersensitivity reactions to the contrast agents, and therefore there was no toxic damage on any organ, so there was no direct relationship between the injection of SonoView and any damage in any organ, but these were only general allergic reaction that might occur with any substance, any drug, even with food. And therefore the restriction was removed, and only there was the need of a mention of the particularly attention paid when there is an examination of patients with acute coronary syndrome or other unstable cardiac condition. And this is why I mentioned that before injecting, we only need to take the history of patients and ask whether the patient had any active ischemic cardiac disease in the last weeks, 4 to 6 weeks. However, at that time, while the committee was investigating this situation, in Italy we decided to perform a retrospective survey on the incidence on adverse reaction in the clinical practice, due to the fact that the impression was that the rate of adverse events was negligible. And I want to mention that this fatal reaction occurred in patients that were investigated also for cardiac disease. And so these patients were mostly affected by cardiac disease and ischemic cardiac disease. Whereas when we investigate patients with abdominal disease, usually the rate of patients with cardiac disease is the same as the general population. So also the risk of dying for cardiac disease because of an independent event is the same as in the general population, which is different from patients with specifically cardiac disease. So we collected this retrospective series, and this series was published, and as you can see, it was a very large study involving more than 20,000 patients. The collection of the events was categorized in serious, according to the Italian ministry, which are events which had a lethal outcome, or caused prolongation or need of hospitalization, or were considered of potential life hazards, or caused significant or persistent disability, or were just held as relevant by the physician in charge. Or clearly the classification also implies causing congenital abnormality or defects, but these were never utilized, and so there is no report up to now of any of such situation. The second group is non-serious events. These are graded as mild, those not causing inabilities and self-recovering, moderate when not causing inabilities but requiring support or treatment. So this does not mean that it is required the pharmacological treatment or but even the support of the health staff, and severe when causing temporary inability and requiring treatment. Out of these more than 23,000 serious abdominal investigations with Sonoview, 92% of which were dedicated to the liver, and the near totality with low mechanical index ultrasound scanning, there was an incidence of total serious events of 0.008%, with a total incidence of events of 0.125%. So there were 29 cases of adverse events, 2 of which were considered serious, and 27 not serious. So looking in greater detail, which was what happened in this situation, we could see that these 2 cases were bronchospasm, dyspnea, hypotension, and low heart rate, a condition that altogether was found to be caused by an allergic reaction. And this was a patient investigated for suspicion of metastasis of colon cancer. And the second study was not a serious study, it was a contrast-enhanced Doppler study because of a renal artery obstruction, which was already treated twice with stenting, and there was a need to investigate whether the stent was patent or not, and this was unclear, so the patient was undergoing enhanced Doppler study. And also in this case, the patient had hypotension with loss of consciousness, lumbar pain, so probably this was also a case of allergic reaction, and the final outcome, she required resuscitation, and the final outcome was the loss of the damaged kidney, which already had a renal obstruction, and following hypotension, there was an irreversible progression of the damage. So this was also a severe event, but also of allergic type. And there was only one serious adverse event in the liver, because as I told you, the second was while investigating the renal artery. Of those that were not considered severe, that were not considered serious, one was severe. It was a case of dyspnea with bronchospasm, which rapidly responded to steroids, so the patient did not require the assistance of the anesthesiologist, and he was discharged quickly after the investigation, but after injection of steroids. So also in this case, it seemed to be an allergic reaction, and also the moderate case were of allergic type, whereas those that were considered mild were probably also aspecific. So altogether, the rate of adverse events is very low and is to ascribed to allergic reactions. One may wonder whether there is an underrating of adverse events, and I must say that since this was a retrospective study, probably there is an underrating, but only for mild events, because all serious and severe events are well remembered by the physicians, and the risk of under-reporting these events is negligible. Indeed, in our local experience in Bologna, we performed more than 13,000 cases in 2 units. We had 1 case of allergic reaction which recovered but required resuscitation. And indeed, this is exactly the rate of 0.008%. And I want to point out that in this case, it was not the first injection, but it was the 4th time that the patient was undergoing injection of Sonoview. So you have to be aware that the risk of having allergic reaction is present even though the patient had already undergone other previous contrast investigations. So what is important is to know when we have to take care of our patients. So looking at this series, we could see that both cases in the study and the one that also occurred in our center after the completion of this study occurred within 2 minutes from injection. And also most of the non-serious occurred immediately after the injection. And this is very logical and as expected with allergic reactions, and also similar to what happens with radiology contrast agents. In a very large study after intravenous contrast for urography, the large majority of allergic reaction occurred within 20 minutes. So there are very few prospective data, but as I mentioned to you, the severe reactions are not forgotten by the physician, so the risk of underrating them is very low, and the risk of missing some severe events that occurred later on is negligible. So what we can state is that if there is a severe reaction, this occurs while the patient is still lying on the bed. And this is really very helpful because we are sure that we can manage personally all the difficult situations. In the pre-marketing data of Sonoview, these pre-marketing data clearly are more focused on safety, so there is more concern and the risk of underreporting is not present because everything is to be reported. And also in this case, there was 1 case of skin rash, which is probably drug-related, and only 1 serious adverse event, which was an anaphylactic shock, and no death in all these cases. So this is the pre-marketing situation, and after marketing and many injections, our retrospective review and showed that the rate of events is 0.8 every 10,000 injection, and the vast majority of the cases is related to allergy. The occurrence of cardiac events probably now can be interpreted as an event which is triggered by the hypotension induced by the allergy. So it's not a direct effect of Sonoview on the heart, but the allergic reaction determines a decrease in blood pressure, and clearly patients with coronary artery disease are more exposed to the risk of severe events in case of hypotension. So I think that nowadays the mechanism is very clear. What are the rates of post-marketing data produced by BRACCO, which is obliged to report this data? You can see that the rate of serious adverse events, which are these red squares, has remained stable over the years, whereas the non-serious events, the triangles, increased in the years in which there was great concern raised by the European agency. So this is an agreement with what I said before, that the severe events are not forgotten by the doctors and are reported, and you can see that these have not changed over time, whereas some mild events are overlooked by the doctors and are reported only when there is more attention on the situation. Have you seen that more attention was present in the time where the European agency reported this problem, but then decreased later on. So it may mean that some milder events are not reported. But milder events has also little clinical relevance and are not very important for the doctors and also for the patients. So up to now, in the post-marketing, there is only one case of death, which was a case of severe anaphylaxis. So if we take the data produced, we can see that the rate of adverse events related to Sonoview is for sure much less than that of ionic contrast agents for radiology, and also about 1/10 of the rate of non-ionic agents, and is comparable to that of gadolinium. So if we take into consideration, when we have to investigate a patient with contrast agents, all the different techniques, MRI, CT, or SIUS, we can say that the risk related to the injection of the contrast agent is least when we use contrast-enhanced ultrasound in comparison to CT, and potentially also in comparison to some gadolinium contrast agents. And if we want to categorize this rate of risk with SIUS, and we compare it with other agents, we see that, for instance, antibiotics have a much higher rate of allergic reactions than Sonoview, and also some on most analgesics and common antibiotics. So altogether, the risk of allergic reaction with Sonoview is minimal, and is to be categorized in the low-risk agents in a scale from low, intermediate, and high risk of allergy. So altogether, we didn't have up to 2007 more data on other contrast agents, but it could be hypothesized that the rate was similar. However, the risk, despite very low, is present, and so ultrasound contrast agents are to be administered only when clinically indicated. And both the duration of exposition to ultrasound emission and the acoustic power emission should be kept as small as possible. So the shorter the time and the lower the energy are recommended. What are the practical implications of this data? We inject the contrast through a vein, so it is recommended to keep the line to the vein patent for at least 3 to 5 minutes, because this is the time when severe events occur. So if there is already a line open, it is much easier to inject the drug by which we can treat a potential adverse event. The second point is that, at least in Italy, we always require an informed consent to be taken from the patient, preferably written. This is what we do. And when we inform the patients, we tell what I've told to you now. You are undergoing an investigation. We explain to the patients why he is submitted to this investigation and what are the results expected from the investigation. And we tell that there is no any organ that is subject to any specific risk with these agents, and the only potential risk is that of an allergic reaction. And to make it clear to the patient, I usually say, you are driving your car every day on the roads, and you know that there is a minimal risk of adverse event that does not depend on what you do, on how well you drive. Even though if you drive it perfectly, there is a risk, but you go every day on the roads. And this is more or less the same. Even if we perform it perfectly, there is a minimal risk. But that is so limited that when there is a need for this investigation, all the patients undergo it. And this is usually something that the patients understand very well, because they go every day on the road and they accept the risk. And so usually we never get a refusal to sign the informed consent. So we only investigate whether the patient had a cardiac ischemic event. But this is not an absolute contraindication, because in some situations it might be more important to achieve a diagnosis, especially in case of malignancy, than resorting to other techniques which might have stronger contraindications. So you have to inquire and decide what is the best risk-benefit ratio. So altogether, my talk could be concluded at this point. But 3-4 years ago, in 2007, something happened which raised some new points. No contraindication at that time were defined for opsison and Definity, which were used in USA for improving cardiac border identification, and Fersonazoid, which is registered in Japan. In the United States, they use contrast agents to improve the delineation of the cardiac borders, and this is also an important task and is accepted in the guidelines. Contrast echocardiography can convert a technically difficult, non-diagnostic stress echocardiogram into an accurate diagnostic study and avoid either an unachievable or a misdiagnosis. So you get more information in people who are not suitable to conventional ultrasound, and this translates into a better management of these patients. So this obviates the need for alternative testing and improves efficiency, resulting in cost savings. So it seems very easy. However, abruptly, in 2007, the FDA released a black box, which is a warnings on ultrasound imagings, because of some reports of a temporal relationship between injection and some lethal cases. This is very similar to what happened in the Europe, but in the United States, again, they wanted to make a committee and investigate what was happening. But a black box at that time raised many concerns by the physician, because it was received for 5 deaths on over more than 2 million injections in cardiac patients. Contrast media in cardiology challenges other techniques to investigate cardiac function, not free from any risk. So it means that if we cannot investigate our patient by echocardiography because he's not suitable and we cannot inject contrast, it means that the patient has to be submitted to another technique to have the same information. So from a legal point of view, the agency wanted only to protect the products. Let's say we don't want products which have even a minimal risk of adverse event, even though it was still to be demonstrated there was a risk between the injection and the death of the patients, because most of these patients were very severely ill patients. We had a risk of dying whatever the investigation was performed. But anyway, the agency wanted only to protect, let's say, the safety of the product, whereas as physician, we want to protect the safety altogether of the patient. So if we cannot get information with injection or contrast agents, we have to submit this patient to other techniques. But this means that we produce a risk of dying of the patients because of the other techniques. Because, for instance, it is reported that transesophageal echocardiography has a risk of dying of 0.01%. So we product, by putting a black box, it became clear that it was a protection of the agent, but not a protection of the patient. While the aim of the physician is maximizing patient benefits, not guaranteeing the total safety of any single procedure. So this is clear, this is accepted in the guidelines, that the mortality rate for transesophageal echocardiography, which might be the technique to resort when the transthoracic is not clear enough, has a mortality rate of 1 every 10,000. So it is higher than the risk of injecting the contrast. So following this black box, very famous cardiologists in USA wrote a letter to, which was published in the literature and was addressed to the committees, saying that we do not believe that these new black box warnings reflect the proven efficacy of ultrasound contrast agents, their established safety record, the potential risks of alternative procedures, and the likely confounding effect of pseudo complications. So at this point, there was a different view between physicians who strongly believed in the usefulness of contrast-enhanced echocardiography and the agency or regulatory agency. So to demonstrate from a scientific ground that the black box was a mistake, there was a collection of large series. These are some of them. You can see that patients who received contrast echocardiography had an incidence of serious serious adverse events very low, and similar to the one reported for abdominal contrast-enhanced ultrasound, letting think that probably this is only a matter of allergic reactions. And indeed, about 2/3 of the patients who had adverse event had a previous history of allergy. These are some of the studies, and as you can see, these were retrospective studies, very large studies, starting from this one of about 2,000 patients, which demonstrated that there were no differences in the rates of severe adverse events and death within 24 hours between patients undergoing contrast echocardiography and conventional echocardiography. So you see that the rates are absolutely the same. Clearly, if you just see that a patient is injected contrast and then dies within 24 hours, you may think about a causal relationship. But you should consider that these are all severely ill patients, so they imply a risk of dying within 24 hours, whatever you inject or you administer to them. And indeed, this comparison clearly shows that the risk is not related to the injection of contrast. This is a slightly larger series, altogether very large, 42,000 patients in 3 different institutions. And also in this case, there was not any difference from matched cohort of patients not receiving contrast. This was published 1 year later. This is probably the largest study because it involves millions of patients, which is absolutely reliable, and they could demonstrate that out of these patients, the 58,000 that received contrast and ultrasound had a difference in comparison to the non-contrast ultrasound, but in the sense that they lived longer. So even though there might be a risk of allergy because of the injection of contrast, altogether the improvement in the assessment and management of patients by using contrast leads to a longer life. So following this retrospective study, one should state not that it is not recommended in cardiac patients, but that it is recommended in cardiac patients. And so all these studies, even this one, which was performed on 66,000 cases, so these are very big studies with both contrast agents utilized in the United States for echocardiography. There was only limited risk of anaphylactic reaction, which was exactly the same rate that we observed in abdominal studies in Italy. So I think that nowadays it is clear that the risk is extremely limited and it is only of allergic type. And this review considered all the studies that I mentioned up to now and clearly showed that the efficacy of contrast agents clearly is in favor of a very safe profile of these agents. So following these studies, the boxer warning for Definity and Optison was changed from contraindication to warnings, and there is a warning of worsening or clinical unstable heart failure and acute other severe situations that are potentially present in any cardiac patient. So altogether, there is a mandate to observe the patients for 30 minutes after contrast injection, but there is no contraindication to the injection. From practical point, in Bologna, we keep our patients for about 20 minutes altogether. That is, we inject the contrast for abdominal investigation or peripheral investigations. We conclude the investigation, we usually is about 5 to 6 minutes. Then the patient is on the line, he takes the paper to clean himself, takes the dresses on, wait out of the door, receive the reports. Altogether, these are 20 minutes, and the patient is free to go because there is no more any risk of severe reactions. So in the end, there is no change in the daily life, at least in Europe, from these warnings. Taking in consideration all these recommendations, The European Federation of Societies for Ultrasound in Medicine and Biology mentioned in the guidelines released in 2008, and this will be renovated in the guidelines that will appear in 2011, how should be the approach to the injection of contrast agents. Users should balance the potential clinical benefit from the use of ultrasound contrast agents against the theoretical possibility of associated adverse bioeffects in humans. The general recommendation are resuscitation facilities should be available because of the risk of allergy, despite it is very little, severe. I repeat it once more, are only about 1 every 10,000 injections. Caution should be considered for off-label use of ultrasound contrast agents in tissues where damage to microvasculature could have serious clinical implications, such as in the eye, the brain, and the neonate. And these are still applications which might be taken with a lot of cautiousness, whereas all other applications are still off-label but are routinely utilized. As in all diagnostic ultrasound procedures, the operator should be mindful of the desirability of keeping the displayed mechanical index and thermal index low and of avoiding unduly long exposure times. And caution should be exercised when using ultrasound contrast agents in patients with severe coronary artery disease. This is clearly expressed. It is only a caution. It is not a complete contraindication. You should balance the advantage of doing it now or waiting 4 to 6 weeks. And sometimes it is more important to have a diagnosis immediately, and we perform contrast-enhanced ultrasound even in patients with cardiac active disease. And as a maximal attention, the use of contrast agents should be avoided 24 hours prior to extracorporeal shockwave therapy because there is a theoretical increase of damage to the gas bodies, but usually after 1 or 2 hours there is no more any gas particles inside the body. But just to be on the safe side, EFSUM recommended to wait for 1 day. So altogether, we can trust that CUS is a safe technique and can be applied regularly in the daily life. Only keep in mind these short and very simple considerations. I thank you for your attention.